Good evening, I'm Hartford Healthcare's Tina Varona. Well, when it comes to the heart, timing is everything, and pacemakers have been around for decades to help pace the heart and keep it in a normal rhythm, and technology has certainly come a long way. Imagine now a pacemaker that's implanted directly into a patient's heart with no wires or leads, and it just so happens to be the smallest pacemaker in the world. Dr. Zweibel is the Director of Electrophysiology right here at Hartford Hospital. He's spending a few minutes with us tonight to tell us more about this. This is amazing. I mean, thank you so much for joining us, but I really want to get into just how small this is. So let's show our viewers. This is the Micra transcatheter pacemaker. Yep. This is the new one, world's smallest pacemaker, and this is the traditional pacemaker, so you can really see the difference here. So let's get right into it. This is for patients who need a single chamber pacing system. Talk to us about what that means.
So we have pacemakers that can pace the upper chambers of the heart, the lower chambers. Most patients who need a pacemaker usually require a dual chamber pacemaker that has a lead in the upper chamber and the lower chamber. The Micra at this point is designed for patients who only need a pacemaker in the lower chamber of the heart, so a ventricular pacemaker as we call it. And it's usually in patients who have chronic or permanent atrial fibrillation, but a very slow heart rate. So they need a pacemaker to prevent the heart rate from going too slow, but they don't need a wire in the upper chamber of the heart. So the Micra is the perfect pacemaker for those patients.
Perfect patient. So just tell us what AFib is, atrial fibrillation.
Sure. Atrial fibrillation is an irregular rhythm that occurs in the upper chambers of the heart. It occurs a lot more frequently as patients get older. Many patients are symptomatic from this, and we have to treat them with medications, but many patients are not. And as they get older, they just are left in atrial fibrillation. They feel well, but on occasion, we have to use some medications to control the heart rate. That could slow down the heart to the point where a pacemaker is required.
Yes, pacemakers. And so this would be the pacemaker for that candidate. How is this inserted? Tell us how you can insert this into the body.
Sure. So a traditional pacemaker, probably a lot of people know, is implanted through veins in the chest into the heart, and then a small incision is made, and the pacemaker is placed under the skin. In thin people, you can see the pacemaker, they can feel it, there's an incision. With the Micra pacemaker, this is placed actually through a vein in the leg. We place a catheter through a vein, a femoral vein in the leg. We use x-ray equipment to guide it into the heart. We place a delivery system that has this Micra pacemaker in it through that catheter into the heart. And using the x-ray equipment, we guide this into the lower right chamber of the heart, and we release it in the heart. So these tines that are on the end of the pacemaker catch into the trabeculae, or the muscle of the lower right chamber of the heart. We give it a tug to make sure it's in place, and there's a little tether that holds the device into the delivery system. Once we're sure that the pacemaker is in a good position, we cut that tether, we pull the entire catheter and delivery system out, leaving the pacemaker, the Micra, behind, that sits in the right ventricle.
I mean, that's literally the size of a pen cap or a vitamin capsule. I mean, it's so tiny. And the other nice thing about this, as we mentioned, there are no wires, there are no leads. You're not going into the blood vessels like you would be using this type of pacemaker, right?
Yep.
So talk to us about that.
Yep, so we find that patients who have traditional pacemakers with leads and wires, most of the complications come from those leads and wires. We can poke a hole in the heart muscle wall, the lead can dislodge or move. Over time, especially in younger patients, the lead can fracture. And so by eliminating those leads and just having the pacemaker as one self-contained device eliminates a lot of that. Also, infection. If people get a transient bloodstream infection, that can infect the wires. With the Micra pacemaker, it's much less likely to become infected. So it's a great device to be used all around. The device also is MRI conditional. Most new pacemakers we're putting in nowadays at Hartford are also MRI conditional, so that's helpful. The battery lasts about 10 to 12 years, and it also has a crystal in it that can detect when you're moving. So if you're moving quickly and your own heart rate is incapable of increasing to give you more blood flow, then the Micra will do that for you.
Wow, that's incredible. We're talking with Dr. Zweibel. He's the Director of Electrophysiology right here at Hartford Hospital. This novel new approach, the world's smallest pacemaker, this is really incredible. This is more of a conventional pacemaker, which requires leads and wires that we were just talking about. But this is sort of the here and now and the future. I can't imagine these could get much smaller, can they?
Well, I don't design them, but I have to expect that maybe they can.
Right.
And certainly for us, the holy grail would be a smaller device, certainly. Also devices that might be able to be placed into the upper chamber of the heart, or even into small veins to pace the left lower chamber of the heart for some of our patients who have heart failure, and then having the ability for these devices to communicate with each other. And so that way we can have the functionality of a dual chamber pacemaker or even a 3-wire pacemaker with completely leadless or wireless devices.
I'm sure that is in the works as we speak here.
I would guess.
I would think so. Now, when you have something like this, also the procedure itself takes about what, under an hour?
Yep, usually about 45 minutes to an hour. It's not that much less time than a traditional pacemaker, but again, it's done through the vein in the leg, and many of these people go home the same day or the next day.
Now, you were also mentioning that you can communicate through the chest wall cavity with the pacemaker. Tell us how that works.
Yep, so we like to check the pacemaker to make sure the Micra is sitting in a good position. We make measurements off of it. We can change the heart rate that the device is pacing and some other parameters. And so we have a programmer head that we use for traditional pacemakers. We put that right over the chest, and that actually can communicate with the Micra, and we can get some diagnostics off of the pacemaker. We can look at how well the battery is doing and how long it has to go, and then we can also make some reprogramming changes as well.
Yeah, and of course you've had 3 patients so far that you've implanted this here at Hartford Hospital.
Well, we have 5 total. My partner, Dr. Friedman, has done 2. I've done 3. And they've all gone quite well so far.
Oh, that's incredible. So what do you say to patients out there, what should patients know about this pacemaker?
Well, I think patients certainly need to know that it's an option for patients who need a pacemaker. It's certainly not an option for everybody. Again, if you need a 2 or 3-wire pacemaker, then the Micra at this point may not be for them. But it's certainly an option out there for patients who require a pacemaker.
Yeah, and are patients surprised, like when you, the patients that you've implanted with this, have you shown them this? Are they surprised? What has been their reaction?
Oh yeah, they're absolutely thrilled. Most patients have no idea that this even exists. And to be fair, we've only recently started putting it in at Hartford. And I think a lot of them are happy that they don't need to have an incision in their chest, that they don't have to worry about the wires. It's all self-contained.
And that you can't feel it too. I mean, that I think was important. I mean, if you compare it to this, I mean, that's quite a significant difference.
It is, and again, in patients who are very thin, especially elderly patients who are thin, many times you can actually see the pacemaker or even the leads underneath the skin. That can be bothersome. In very thin patients, the pacemaker, the leads could even erode through the skin sometimes, and so again, that's why for those kinds of patients, something like a Micra would be ideal.
And we want to just reiterate that this is for someone with a slower heartbeat, not a faster heartbeat.
Nope.
How would that work with a pacemaker then?
Typically for patients who have fast, dangerous heart rhythms, we implant devices called defibrillators or ICDs. Those devices still require leads or wires. We haven't gotten to that point yet. And then for patients who have fast heart rhythms that may not require a device, for example, arrhythmias, we can then put catheters inside the heart and burn away extra pathways called an ablation and cure some patients from their arrhythmia. So everybody's a little bit different. So I don't expect a patient to walk into my office and say, give me a Micra, but knowing that Hartford has this technology available along with everything else, it's something that we can offer to our patients.
Sure, it's just another method of treatment that you can offer them. Again, we're talking with Dr. Stephen Zweibel. He, of course, is the Director of Electrophysiology here at Hartford Hospital. Thank you for joining us on this Facebook Live session. We ask you, or invite you, to ask Dr. Zweibel a question about whatever it could be. Atrial fibrillation, it could be this new pacemaker, timing of the heart. He's here to sort of talk about the electrical part of the heart. You're sort of the electrician of the heart, if you will. Are we seeing this, is this quite common, folks with a slower heart rhythm that would require this single chamber pacemaker?
Yeah, I'd say probably of all of the devices we put in, probably 10 to 15% at least require a single chamber pacemaker, may be a candidate for the Micra. Certainly as our population ages and we see patients living longer, we do see patients more often requiring a pacemaker or a defibrillator for that fact. So,
what would actually cause atrial fibrillation and a slow heartbeat?
Well, certainly atrial fibrillation can be caused by a number of things: hypertension, that's not treated well, sleep apnea, lots of other different disorders. And as patients get older, they're more likely to develop atrial fibrillation. They also develop disease in other places of their heart, not only in the upper chambers, but in the electrical conduction system of their heart. So some patients who have atrial fibrillation can conduct that atrial fibrillation very rapidly through the conduction system of their heart to the lower chambers, and they have rapid, irregular heartbeats and palpitations and shortness of breath. And then there are other people where their conduction system of their heart is diseased and the atrial fibrillation doesn't conduct well at all. As a matter of fact, it doesn't conduct well to the point where they have a slow heart rate. They become symptomatic from that slow heart rate, and then they require the pacemaker.
Yeah. What are some of the symptoms that you would experience if you have AFib and a slower heart rate?
Well, it could vary, but usually patients who have a slow heart rate that are symptomatic can be tired, fatigued, short of breath, especially with exertion. They can get lightheaded, they can get dizzy, and then if the heart rate is slow enough, they can actually pass out. They can lose consciousness. And so these are the whole realm of symptoms that patients may experience.
Yeah, and it's not something to take lightly. I mean, if you are experiencing these symptoms, of course it can be a number of things, but honestly you want to just go and check with your doctor for sure and have that workup and find out what it is, because if AFib or a slower heart rhythm is left untreated, that could you could suffer serious consequences.
You could certainly. Atrial fibrillation is one of the leading causes of stroke in the world, probably, and so being on a blood thinner if you have atrial fibrillation potentially is something that you need to look into. And then developing a weak heart from too rapid a heartbeat with atrial fibrillation is also one of the risks of atrial fibrillation. So you may need medications to actually slow down the heart rate. Right. And then we've discussed having too slow a heart rate with atrial fibrillation and being symptomatic from that. And again, there are a multitude of different ways of treating patients with atrial fibrillation. Sometimes we leave people in atrial fibrillation. Many times we convert them back into their normal rhythm, and we give them medications to try and keep them in their normal rhythm. And that makes many patients feel better. They have a much improved quality of life. Sure. For patients where those medications fail to keep them back in their normal rhythm and the atrial fibrillation keeps coming back, we then can do ablation for atrial fibrillation. And we actually recently started doing not only radio frequency ablation, which we've been doing for many years, but we recently started doing cryoablation, where we have a balloon. I think Dr. Crespo,
we just had him on.
Yep, spoke about that recently. He's one of my associates, and so we've been using cryoablation for atrial fibrillation. So there are a multitude of different ways to treat atrial fibrillation, from doing virtually nothing to medications, ablation, and even a pacemaker.
In what case would you not treat the AFib?
So I think if someone shows up and has atrial fibrillation and is completely asymptomatic from it, who's had it for quite a while, then many times we will just leave them in atrial fibrillation, so long as their quality of life is good. And then we'll talk to them about a blood thinner if they're not already on a blood thinner to prevent a stroke, or a heart attack if they're a candidate for that. But usually patients who are completely asymptomatic. Right now we don't have any solid data saying that if you have atrial fibrillation and we get you back in your normal rhythm, that you will live any longer or have lower chance of having a stroke. We were involved in a study called Cabana that looked at that. We're waiting for the results of that, so this may change in the near future. Right. But right now the data is that if you're completely asymptomatic with atrial fibrillation, that
you can live with it.
That you can live with it, exactly. But what I also see is patients who come in who think they're asymptomatic from it, and then I talk to them a little bit, and then I pull it out of them. Well, I'm just getting old, and maybe I'm short of breath walking up the stairs because I'm old, and then we convert them back into the normal rhythm, and they come back into the office and they go, wow, I actually wasn't symptomatic. I feel much better. So some patients get used to it, and it's just, well, I'm just getting a little bit older, and that's the way it is. But sometimes getting people back into the normal rhythm can surprise them and actually make them feel much better, at which time we then become pretty aggressive at trying to keep them in their normal rhythm, so they have a better quality of life.
But it's also important for the patient too to tell you exactly their symptoms and how they're feeling, so that you can properly treat them in the right course.
It is, but sometimes they're not fully aware. It has to be pulled out of them. You have to ask the right questions, and they think about it. They go, yeah, you're right.
Come to think of it,
I used to be able to walk all the way to the store without stopping, and now I feel kind of tired and I don't. So
for folks with AFib, if they have members of their family who have heart disease or AFib, is this hereditary?
Not typically. AFib kind of hangs out with things that are hereditary, like hypertension, for example. And so we see a lot of patients whose relatives have atrial fibrillation, but not necessarily because they have a genetic defect. It's just that other things like hypertension run in the family and would lead to that as well. And so there are rare genetic forms that have been found that lead to atrial fibrillation in younger people and families, but that's
Now, if someone younger needed this type of pacing, and they're very active, or they want to lead an active lifestyle, would they be able to do that with this pacemaker? Could they pretty much do their normal activities?
They could. Again, most younger patients who might require a pacemaker are actually in normal rhythm in the upper chambers of the heart, so they would probably benefit from a dual chamber pacemaker, so they would need the one with leads. But if for some reason even a middle-aged or slightly older person had atrial fibrillation chronically, was always in it, and needed a single-chamber pacemaker, they would easily be able to get the Micra, and then they would, after everything healed up, they would be able to do whatever they wanted to do. They'd be able to exercise and do whatever they wanted.
Yeah. Well, I got to say, this is quite remarkable. And I would think as a physician, this is pretty remarkable for you, too, to see that, right? Because after so many years of implanting this, now you go to that. What are your thoughts?
No, absolutely. I think it's a great first step from my standpoint. I'm always a guy who wants his cake and wants to be able to eat it, too. And so I want to see them a little bit smaller, even though this is incredibly small.
Yeah.
And Medtronic, the company who's made this, has done a fantastic job with this technology. And I know they're almost certainly very hard at work at a device that pays attention to what's going on in the upper chamber of the heart, potentially devices that speak to one another. There are a lot of technical challenges to that. You have a beating heart, you have blood, patients moving a lot, and so there are a lot of technical challenges to getting this done. This took many, many years and a lot of money in research. So I know they're working harder to make me happier and all of our patients happier.
I have a feeling we'll be seeing you back here very soon with something probably half that size.
I hope so.
Well, thank you very much for sharing this with us. We really appreciate it. Dr. Stephen Zweibel, who's the Director of Electrophysiology here at Hartford Hospital. And we, of course, thank you for joining us. We hope you got something out of this. I sure did. So thanks again. We'll see you back here next week. I'm Hartford Healthcare's Tina Varona. Have a great night.